So our panel is complete with Professor Tripathi, Professor Das, Dr. JJ, and Dr. KK. So it's one of the best panel so far. And Tripathi sir, you wanted to say something.
Okay, thank you. Thank you. I have nice presentation from JJ. Looks like JJ, great English man. Okay.
Yeah.
You
As
had
usual,
wonderful
sir.
coverage on the GLP-RA, and the kidney part has been very important to the nephrologist fraternity. And we have many questions. Almost all the trial which you have narrated have shown that it has an advantage, and some of the trial has a wonderful advantage in relation to the sustained 6 trial, which have shown almost close to 26% in reduction of the doubling of the serum creatinine, and also in decrease of the proteinuria, 46% reduction. That was one part over there. And rest of the like award trial and the LIRA trial, which was specifically related to the LIRA kidney, have shown. But overall, when you look at the bottom of the whole landmark trial, they did not have shown any advantage over the overall death as we have got in the MACE and or in the cardiac event as the CVT outcome. So in that perspective, reduction of proteinuria, reduction of the albuminuria, reduction of the blood pressure, systolic blood pressure, and also to some extent on the glomerulosclerosis. How you perceive now and how we convince the nephrology fraternity to use GLP-RA in the patients who want to also get the same advantage as we get in the cardiovascular outcome.
Sir, this ball, I will just quickly return back to you, sir. No better person to answer this question than you. You are the nephrologist amongst us. You are using these molecules. Do you still want me to answer? आपके ऊपर नहीं बोलने का, sir. आप please बोलिए. इसमें
See, the reason was because you have reviewed the whole thing. Nephrology fraternity somehow they have, as they welcomed the SGLT2 inhibitors and they started writing prescription for that. GLP-RA, number one is the cost as one factor. Number two, by the time the person comes to the nephrologist, he has got a lot of GI manifestation, he is not eating well, he is a fluid overload, has got a sclerosis, hypertension is very bad. They are using 4 or 5 drugs. We have to use 4 or 5 drugs in a very heavy dose to get on to the reduction of the blood pressure. In that perspective, looking at the, as I said, sustain has shown the wonderful outcome. But in practice, this is not being translated.
I'll add on to that, sir. Obviously, overall GLP-1 receptor agonists use not only in renal issues, overall their use is minuscule. I had one slide which showed that 1 in 10 people who deserve GLP-1 get GLP-1. Reason being, number one, I said 100 times you have to say cost in India, even overseas. I have a slide which shows the use of GLP-1 RAs even in US, where in the last, from 2006 to 2013, that data stopped at 2013, the rise of use was from 2.3% to 4.8% or so, as compared to all of the drugs which are 40 to 60% used. So GLP-1 RAs worldwide are not being used. As in the interview also with Denise, he accepted there's the cost. It's always the cost which is an issue, especially in a country like us where it's an out-of-pocket kind of a market. Second reason being injectable. So people who can afford maybe might want to try oral semaglutide. With regards to the kidney functions, SGLT2 inhibitors any day have a much better outcome with regards to renal outcomes than GLP-1 receptor agonist therapies. We have dedicated SGLT2 renal trials. You know them very well, DAPA-CKD. We have dedicated renal trials. Credence we have. Whereas with GLP-1 receptor agonists, as of now, they're all secondary kind of data from the various trials like Sustain 6. For that matter, the latest Rewind trial had a complete section on the renal outcomes of Rewind trial. But the renal outcomes are not as impressive as SGLT2 inhibitors. As you very rightly mentioned, majority of its benefit is proteinuria, whereas the clinically significant renal outcomes, as we say that 40 or 50% reduction in HB in EGFR and renal death or end-stage renal disease. The data is statistically significant with some of the GLP-1 RAs, but not as impressive as with SGLT2 inhibitors. So GLP-1 RAs are underused, not only in our country, but everywhere. Having said that, what I feel is sometimes we also hesitate in offering it to people who might be able to afford it. So my plea is that when you see a patient, I mean, of course, first impression you get some idea whether he or she can afford. If they can afford, then probably offering GLP-1 RAs are a good option for with regards to glycemic control, weight reduction, blood pressure reduction, lipid reduction, and unequivocal cardiovascular benefit with the four molecules that I discussed, and added some renal benefits, but not as good as SGLT2 inhibitors. I'll stop here.
I get the same,
Yeah,
right?
yeah.
Because after sustained trial, it must have a lot of potential to be used. Professor Das has been talking a lot on cardio-renal axis and the connections very often. Sir, you all quickly.
Yeah. Actually, very well taken, Dr. JJ. Before we go to KK, I'll request Dr. Kanungo to allow some more time because we have the full panel and very interesting topic of GLP-1 and insulin. We may not finish at 8. So maybe the entertainment...
At 8:15?
Maybe 8:20.
Okay.
Yeah, if we give half an hour, it will be 20 minutes past 8. So we'll try to take up the questions as quick as possible. And I'll start with Dr. KK. You wanted to share a video, Dr. KK.
No. I was unable to open my video because it was blocked. So I had asked them.
Yeah.
But thank you, Jayant. I think adding on to Professor Tripathy's question, there is one other thing which I wanted to add here about the GLP-1 receptor agonist use in renal disease. As yet, I'm a bit unclear still about the effect on retinopathy of the GLP-1 receptor agonist. You know that renal failure patients have got more retinopathy. And although the companies have been quite eager to convince us that it is the sudden drop in HbA1c which is responsible for the retinopathy, I somehow don't buy that. I think there is more to it than meets the eye. There's something else which is happening. So what should be our when we are using it in renal failure patients, what should be our standpoint if a patient has got established retinopathy? Should we be using it? Should we, if we use it, should they have more frequent monitoring? So these are unanswered questions with the GLP-1 receptor agonist use.
Kamalakar, I just wanted to say, KK, one important issue is that even though initially there was worsening of the retinopathy, I would like to know from you and JJ and Kamalakar, what was the ultimately what happened? Ultimately what happened? I mean, ultimately at the end of the trial, did it equalize or did it not? Because all the trial which showed with glycemic control retinopathy worsening, whether London trial, Hevidar trial, Paris trial, you know that at the end of 2 years, they all became equal. So was such thing found, JJ, in the
Sir, this retinopathy story with GLP-1 RAs is definitely a negative for GLP-1 RA. There's absolutely no doubt that use of GLP-1 RA worsens retinopathy. It happens with all the GLP-1 RAs. Some escape by it not being statistically significant, and in some it was statistically significant. Sustain 6, unfortunately, was unequivocally statistically significant deterioration in retinopathy. And this was a side effect which led to the stoppage of the medication in some of the trials. Same thing happened with dulaglutide, same thing happened with liraglutide, but they did not reach statistical significance. Same thing happened with oral semaglutide. So coming to Kalyan's question, it's a very difficult question to answer.
Did it stabilize? Did it stabilize after some length of time?
No, sir, see, these trials were for very short duration, you see, and after that they were not followed up. So there was statistically significantly increased retinopathy in the arm which was getting GLP-1 as opposed to the placebo. So in the background therapy. So there is no question that GLP-1 RAs worsen retinopathy. Now coming to Kalyan's question as to whether you would be using it, and especially in nephropathy, Dr. Kamalakar Tripathy would probably feel it better. See, I still do not know the lower GFR cutoff for stopping GLP-1 RAs. With regards to dulaglutide and liraglutide, I am told that I can use it up to eGFR of 15. Now, I would never go below 15 for using GLP-1 RA. For that matter, maybe GFR of 30 may be a better place to cut off. Whereas with regards to some of the others, even GFR of like lixisenatide and exenatide, eGFR of 45 is the cutoff. So as it is GLP-1 RAs in end-stage renal failure, I would not be using. If they have retinopathy, I think my stand would be to assess the retinopathy, whether it's proliferative or NPDR with or without CSME. If it's NPDR, very mild NPDR, no CSME, I would be happy to continue with my GLP-1 receptor agonist therapy. But instead of yearly eye screening, I probably might say 6-monthly eye screening. If it is NPDR with CSME, with cystic macular edema, or proliferative retinopathy, I would not be using a GLP-1 RA. That is my stand. I think Kalyan, do you want to say anything to that?
Well, I think I completely agree. Background diabetic retinopathy should not be a contraindication. In my practice, I never use it GFR less than 30 because the ABCD trial, Association of British Clinical Diabetologists audit showed that the GI effects, side effects of the GLP-1 receptor agonists are far more when the GFR goes under 30. So although you're allowed to use it till 15, you'll have more GI effects when you're using it less than 30. So 30 is my usual cutoff. And Professor Das, your question about over a period of time, where did it equalize the effect of the retinopathy? You see, what I was trying to say was that one of the reasons given was the sharp drop in HbA1c. Exactly. But you see, in the dulaglutide, in the rewind, I think the baseline HbA1c was 7.3 or 7.4. There's no sharp drop there. Still, the signal is in the wrong direction, even for the rewind trial. So that tells us that there is something to it. So I think this is a minor issue. It should affect a minor number of a small number of patients, but still something to be we should bear in mind.
I think is it prudent to say that three situations where we will not give it? Advanced retinopathy, as you rightly said, proliferative beyond certain stage. Number 2, pre-existing maculopathy, and third, a very long duration diabetic. This drug is possibly not that benefit. So I think the practitioner's take on this should be don't use it. You correct me if I'm wrong because I have not used it that much.
I will add a few more.
There's 1 minute. There's 1 minute. Pre-existing maculopathy. Number 2, if the patient has advanced retinopathy. Third, a long duration diabetes, which is likely to have retinopathy. JJ, what to it?
So I think the first and foremost is history of acute pancreatitis or past history of chronic pancreatitis. Yeah, even though GLP-1 RAs have not shown to increase it, but pancreatitis is an absolute contraindication for a GLP-1, for any incretin for that matter.
Yes, exactly.
Second is situations where there is increased risk of pancreatitis. This is a relative contraindication, like somebody having a large gallstone, multiple gallstones, or triglycerides above 500. I would rather not use a GLP-1, for that matter, any incretin, GLP-1 RA being one of the incretins, I would rather not use. Third one is very, very rare. I've not seen in my career yet. I've seen in endocrinology wards, but never in a diabetic. That is a medullary thyroid cancer or MEN2 family. I've never come across. If I come across that, a case report of a diabetic with MEN2. That's where it's contraindicated.
JJ,
yeah.
What we find from this discussion that GLP-1 should be thrown to sea.
No, absolutely not.
No. That is what I, as a practitioner, I should gain the impression that this is a very dangerous drug, killing, damaging the eye. Everything it is damaging only. Where should we give it?
Dr. Kanungo, you have
Jayant, I will say that, you see, what JJ said is to sound caution. But the bottom line is that if you take care, see, even this was existent in the DP4 inhibitors. Am I correct, JJ? But yes, when you use it prudently, avoid in patients having previous we do that. To avoid previous pancreatitis, it is absolutely safe. Similarly, in the eye complications, 3 situations. If you don't give in a case of pre-existing maculopathy, number 2, advanced retinopathy, what you just now discussed, proliferative KK and JJ said, proliferative retinopathy, and then you are absolutely safe. And as JJ and KK both said, this constitutes patients. The majority of the patient, we are a game changer.
Dr. Kanungo, I think I should thank you for steering the discussion back. We were going too much into the negatives.
Absolutely.
The reason being is first do no harm. That's why I think that's where Professor Das came in.
We have many young diabetics, obese diabetics, neo-rich people, those who are very obese and fat. They have less than 5 years of diabetes. They do not have retinopathy at all, no nephropathy. They are an ideal condition where we can give this.
Totally agree. Majority of type 2 diabetic patients to me are suitable for GLP-1 receptor agonist. In my talk, I also said, if I am asked what is the best second line drug after metformin, I would probably have a big fight between GLP-1 and SGLT2 inhibitors. And as you rightly said, majority of the patients can get GLP-1. We were just discussing the contraindications. I think you're right. We are talking to a general audience, so we should have been more positive and then come to the relative the contraindications for a drug. Same with SGLT2. I mean, they also have a huge list of contraindications. But I'm grateful to you for pointing this out. Otherwise, you're right.
Thank you, Dr. JJ. Actually, this question point is taken from your presentation by Professor Tripathi, and it has taken the major chunk of discussion. Good that good part of the GLP-1 is covered. We'll move on to insulin because we have completed 100 years of insulin.
Just 1 minute, because I want to dispel something which I consider the people should not go back with that idea. JJ said we have to remove that idea. Our great friend Paresh Dandona, 8 years senior to me. Now in USA, you might remember JJ, KK, all of you remember, he says he starts his patients, type 2 diabetes patient therapy with a GLP-1 RA. Remember JJ? With one SGLT2 inhibitor and metformin. And he said to me, and all of you he has said, that the complications in these cases are much less because the control is much smoother. And as JJ showed that you can address 6 of the ominous octet. You showed that, the JJ. 6 of the
if you add SGLT2, you cover 7 of them. But I think your friend is very fortunate and lucky to be using that combination. He would love to, but
he uses that. Paresh Dandona, I have not heard him. Paresh Dandona uses that. Yeah, and then he says that he's very, very happy with the combination. No, what I was trying to say, that as Alok brought back the discussion to the track, I want to take it on the track a little further by saying that this is a proof of pudding in eating it. And our friends are using it all the world over. There is need for caution. KK, there is a need for caution, no doubt about it. But this is a wonderful drug, possibly used rightly, can produce miracles. Yes, Jayant, you produce. But some more discussion GLP-1 RA before you go to insulin? No. You want to go to insulin?
Go to insulin.
Yeah. We'll go to the insulin because it's 100 years of insulin and still the therapeutic inertia persists.
No.
The most important thing, the physician's mind has not accepted the insulin more than the patient's mind. So how should an Indian physician understand the aspect of the therapeutic inertia? And we'll start this question from Professor Tripathi, one of the most senior nephrologist, diabetologist, and the physician, that he can tell that how to come over the therapeutic inertia. You know, after 100 years also, we have not fully utilized this molecule to give benefit to our patients.
So one group of patients who initially present to us, and all of us agree, Professor Das would agree, who have a very high fasting hypoglycemia. And these are the patients you have to convince the patient, look here, whatever medicine you give, until unless you have insulin, basal insulin to begin with, to start with, your fasting would not respond to. Metformin is not going, because he already has taken 3-4 months or 1 to 6 month trial on the metformin. It would not reduce. If somebody has 250, 300 fasting sugar, it would not respond. That's the one place where we would like to convince the patient that please go ahead with the insulin. That's one area. SGLT2 inhibitors somehow have taken this problem, created problem. People want an excuse. Physician want an excuse to convince the patient, look here, this is costly medicine, you take it and you need not have insulin. But we have to look at the quantum of reduction of HbA1c with SGLT2 inhibitor. It cannot do more than in combination on 1.5 or 1.8, and we have a patient in a different setup. So I think that is another group whose postprandial upsurge is very high. There we need a bolus. And these are the two places where we can convince the patient and the inertia can be broken. Third is the long-term advantages with the insulin, especially as an anabolic hormone. It makes up your good weight. And those patients, type 2 who are lean patient, they don't have body mass enough. You give any OHA, you give SGLT2, they would do weight further. You give metformin to more than 2 grams, their appetite would be very, very bad. They wouldn't eat anything. So lean diabetics, type 2 who are coming to us, again, we have to convince. These are the 3 different setup. Very high fasting, very bad postprandial, and very lean and thin type 2 diabetic. We shouldn't give them a lot of trial on OHA, and they should be convinced. And we should that way break the barrier from the physician side as well as from the patient side.
Thank you, sir. Professor Das wants to say something.
I think, Jayant, we have just published a paper from the landmark trial where we have shown that beyond 3 oral anti-diabetics, the 4th, 5th, and 6th are not that useful. 5th and 6th, in fact, do not add anything. 4th may add something. So one of the ways of convincing patients not to take multiple OADs is the finding from the study. Number 2, I'm very passionate to mention that the insulin and metformin came at the same time. 1920, 21, 22 was the year when metformin came. At the same time, insulin came. The penetration of metformin has been great, but penetration of insulin has not been so great. That responsibility, you pointed out yourself, Jayant, that we are responsible for that because we do not start insulin even in a severe fasting hypoglycemia. For that matter, a very severe hypoglycemia, which is a metabolic emergency. We said in the guideline beyond above 250, and we don't start because we take it very lightly. So as Professor K.K. Tripathi said, there are 2 things. One is unavoidable hyperglycemia before diagnosis. But avoidable hyperglycemia after diagnosis must be combated with insulin. And third point I would like to mention, we have to give to patient the great message that insulin has to be taken if X, Y, Z, OHA are not working, as 3 situations KK pointed out. Number 3, for the benefit of a great sense of well-being. Long before this city UKPDS came, insulin was hailed for its great sense of well-being. And also we have to impress on the people that possibly insulin has the highest potential to decrease blood glucose, highly efficacious, smoother, and current insulins are free from hypoglycemia and any danger. So fill up and feel the difference. Take it and live long. These are the things we to popularize insulin, but I rightly agree with you, Judge. The resistance is with us in our mind and in our pen.
I'll like to ask KK one very simple question. For our Indian scenario, we have high carbohydrate diet with high PPG levels. How do you place this? See the insulin co-formulations like IDEGAS placed in diabetes care, taking into the account these Indian realities, IDEGAS or co-formulations.
Yeah. So I think IDEC ask is definitely an advancement because normally we start with a basal insulin, then we give a bit of time, and this time can be anywhere between 2 weeks to 2 years. Then we add a bolus insulin. So we really cut down the time of glycemic load for the patient if we start with a co-formulation right at the beginning. And multiple trials have shown that it is superior to once-a-day basal. Now, I was listening to the discussion about, I'll just give you an example. The Western guidelines are heavily dependent on starting basal only because of high fasting. But so I'll just give you an example of one of my patients. So she had high fasting and I had started on basal insulin and she started getting hypoglycemia during the daytime. Now, when I did a CGMS on her, what I found was that during the daytime, the sugar levels were fine. And after, say, about 10 p.m., it suddenly took a big jump and it stayed up. So the fact was, it was my mistake not to take the proper diet history because she was having very meager breakfast and lunch. And when all the family returned home at dinner time, she had a huge dinner, and that pushed the blood sugars up, and it stayed up. I was trying to counter that by giving basal insulin, but she was having hypoglycemia during the daytime because she was not eating much there. So what I needed was to give a basal and a bolus with her dinner dose. So I changed to co-formulation, and that did the trick. So I'm telling you this as a case example of our patients, because many of us have a one big meal, carbohydrate high meal in a day, which will be ideal for the co-formulation to be used.
Yeah, thank you, KK. I'll like to go to JJ on a very simple issue. When we are planning a insulin therapy, maybe after secondary OHA failure or very high blood glucose and A1C, there are many school of thought. We advocate initiating with the basal insulin, then going to the basal plus. In view of the high carbohydrate diet and high postprandial hyperglycemia, few advocate why not go with a pre-mixed insulin before the measure meals and then titrate. If you tell no, basal bolus is the best. So what happens? A common physician is confused in the sense how he should go about switching over from oral drugs to oral and insulin or initiating insulin therapy. So how you will scientifically suggest them to move?
Okay, sorry, I'm audible, right?
Yes.
Yeah,
okay.
you're audible.
So it's basically this is initiation of insulin. First answer as to why our doctors do not start insulin enough is, Professor Das, we need to do something about it. We need to get diabetic nurse educators. See, I've worked both overseas and in India. Overseas, I just have to write the prescription. Patient goes, sits with the diabetic nurse educator for half an hour, who teaches everything to the patient, where to inject, how to monitor, how to adjust insulin. After half an hour, patient comes back to me. But my friends in the primary care physicians don't have this time. So time is one of the biggest factors why we are not initiating insulin. When to initiate insulin, Professor Kamalakar Tripathy has very nicely said. How to initiate insulin? Now, it depends on, it will vary from patient to patient. You can't have one formula for every patient. Depends on when you're starting insulin. If you're starting insulin very early, after 2-drug or 3-drug OHA failure, here I think basal works for a quite long period of time. This thing that we've been told that if you start basal after 6 months, basal fails, is probably true in India because we start insulin very late in India. If you follow the guidelines and start insulin early after 2 or 3 OHA failure, you can get away with the basal insulin for 3, 4 years. Now, if you see somebody who's got fasting high, postprandial is about less than 50 milligrams above the fasting value, you can get away with a basal insulin along with your sulfonylurea, metformin, and whatever OH you're giving. If at the very first visit, diabetes is 10-15 years duration, fasting, PP are both high, and PP is more than 50 milligrams per deciliter high. Suppose a fasting is 250, PP is 480. Here, giving a basal alone will not get you to the line. Here, either you start premixed insulin or you go for basal bolus insulin. Sometimes what I do is I look at the patient's face. I know he may not start twice daily insulin. What I do is to buy time, I start him on some basal, get the sugars a little bit better control. Once he's used to the basal insulin once at night time, next time when he comes, when he sees that sugars have improved, but not to target, then converting him to a basal plus or premixed insulin is easier. So what is high? What is the difference between fasting PP and what is the background? If the patient has got a lot of complications, you want to get good glycemic control quickly, patient is due for surgery, probably premixed insulin twice daily or basal bolus, depending on the education level of the patient, depending on how much he or she can do blood glucose monitoring at home, how educated he or she is to adjust the basal bolus insulin. These are all the negatives for basal bolus I'm saying. It's a complicated regime, it's a little bit more expensive regime, it requires more monitoring and it requires more adjustment. Having said that, if you compare a basal bolus with a premixed insulin regimen, there are trials either way, but probably, as you rightly said, Dr. Jayant Panda, basal bolus will probably get you tighter glycemic control as opposed to a premixed insulin in a real life scenario. So I hope I have answered when to start, how to start, and which one to choose.
Yeah, very correct. Yeah, correctly told. Yeah, and Dr. Kanungo.
There should be a message from this platform to our friends doing practice in diabetes. They fear. There are two reasons. Patient has conceived ideas that insulin should not be given early. And second thing, doctors fear that at a certain level they may have a night call of hypoglycemia and other things. But there should be a clear message from us that minimum blood sugar at detection, if it is 300 and HbA1c is more than 9, should we not encourage short use of insulin to our patients? Maybe 2 months, maybe 1 month.
We must, and basal alone very rarely produces hypoglycemia. Am I correct, JJ? Basal will alone, if in proper doses, will produce very rarely hypoglycemia.
Somewhat the basal insulin alone is has been underutilized in India. I don't find many physicians taking basal alone unless they're specially asked for. So that orientation has to come, and it has to start not only much earlier, it has to start with a basal only dose, and it has to be escalated as JJ described with a basal plus or premixed. So it's the responsibility of Professor Das to popularize that, and he will suggest after this 100th year of insulin how to go about. That's what I think Dr. Kanungo wants.
KK has a point. KK has raised the hand.
Well, I think, Jayant, the one thing is, you see, we have to start at the base, you see, from the medical teaching. So when I graduated my MBBS, I knew about the insulin molecule, in, out, everything, but I didn't know how to inject. My hands used to shake if I wanted to start somebody on insulin. And that, unfortunately, is still the case now. You know everything about it. Theoretical knowledge, excellent. But practically speaking, zero. So when these MBBS past people become doctors, they still carry this. So we should all encourage a practical based session on initiation of insulin for our just recently passed out medical graduates. That will solve the problem to a great extent. Because only after MD, we feel confident, okay, now I can start the patient on insulin. That shouldn't be the case. Even MBBS students, it should be able to start it.
And that will not solve the problem of diabetes in India. As long as our juniors or MBBS doctors, even lower below, are not empowered to use, and at what stage and what, that detailed guidelines should come up, and it should be popularized.
And the most important thing, as KK rightly told, the insulin workshops are to be conducted for the freshly passed MBBS students, postgraduates, as well as practitioners. I have taken up for last 2-3 years conducting insulin workshops where the practical aspects are delineated, demonstration of the pens and the devices are done, and people are asked how to initiate, how to optimize, how to intensify, how to go about. And that will rather encourage them, give them the confidence to go what I feel. Professor Das.
So what I am getting is, you are saying, get the diabetic nurse educator course and give it to the primary care physicians. I agree with you. In our country, when we have so few diabetic nurse educators, probably that is a very good idea. Answering Dr. Kanungo's question of initiating insulin at first presentation, I totally agree with you. That guideline Dr. Das has only got out, that if at presentation your fasting is above 250 or your PP is above 350 or you have an HbA1c above 9% and you are symptomatic, then 110% you should start with insulin, be it basal bolus, be it premixed insulin, but patient should be on insulin. What I feel is, if your HbA1c is 9%, you're still asymptomatic, but your fasting is above 200, 250, you should add basal insulin to start with. Why? Because there's a lot of glucotoxicity happening, which is destroying the ongoing beta cell function in that interim 2 to 3 months period. So as Dr. Kanungo says, I totally agree with you, and that's my practice. I start a basal insulin there to get my fasting down, and by the time my oral also starts working, and this basal insulin you can easily stop after 1 to 2 months once you get good glycemic control in a newly diagnosed diabetes.
Jayant, we have 4 minutes to go. It is going to be 30.
So we have crossed our time. Last theme we will take up before we close this session, and that is regarding insulin only, because GLP-1 we have taken up at the beginning. The most important issue is the glycemic variability and time in range, which we are using in the newer practices for the glycemic monitoring. More than A1C, we prefer on these criteria. So keeping in view this, that we monitor our patient with this.
See, I will give a negative answer. You might want somebody else, because to me, time in range is a hype. Time in range is something very difficult to do in our country. Depends on how you're doing a time in range. Are you depending on multiple finger pricks and then you calculating your time in range? Or you want to be a purist and you want to have CGM and then get your time in range? So there are so many issues, you see, where people in India who do not even do SMBG, people on insulin who do not do SMBG, talking about time in range is a little bit elitist, I think. But yes, scientifically speaking, your question is very valid. Time in range is in vogue today. Now, if you want to get best time in range, insulin pump. Now, majority cannot afford insulin pump. Then I would go for basal bolus. Basal bolus you cannot afford, then go for co-formulation. Co-formulation you cannot afford, go for analog to premix. That also you cannot afford, then you come to the human insulins. I'll stop there. Kalyan, do you want to add to that?
Well, I think time in range, I start with the very basics, going through the diet history of the patient. So what you eat in the morning, what you eat at lunchtime. So many a times, Monday to Friday, they have or Monday to Saturday, they have a different schedule of their food, timing, quantity of carbohydrate, and Sunday they have a different one. So if you have the same prescription for the whole week, your timing range will go out of the window. So that needs to be taken into account when, what, and how much. So then this, if you do that, whatever regimes you are using, if you use it properly, then that will result in improvement in timing range.
Very well taken. And you have to see the mass. What is the issue with the majority? And as rightly JJ pointed out, many of us don't expect even SMBG from our patients. So variability, time in range is a dream for them. So I'll not go further. I'll hand over the session to Dr. Kanungo and Professor Das, because we have discussed GLP-1 and insulin in some extent, and it's already half an hour beyond time. Before, yeah.
And the benefit of the session have been great. Number one, JJ has introduced to us a molecule which is a game changer, and he has also pointed out where you have to be cautious. KK has given a great perspectives. Both Kamalakar and KK Gangopadhyay both KKs have said that the insulin use has to be there, and you know, it is not a TIR which of course desirable, but it is not going to serve the purpose. It is by hook or by crook, whatever way you find out the blood glucose, or by hook and crook, try to measure the blood glucose and try to maintain whatever your glycemia possible. You may start with basal plus oral tablet, or basal plus one more insulin in the morning, or you can give a co-formulation. There are so many choices today, but the bottom line is to start insulin when necessary, to escalate appropriately, and to optimize at the correct time. With this note, I hand over to Alok to close the session.
Thank you, Professor Das. Thank you, Jayant. Thank you, JJ. Kamalakar sir, my regards. And KK, all of you have been fluent, knowledgeable academicians, and you communicate very well. You are very good communicators. So people, our audience must have been really benefited out of this. And